you put this in your mind. All trauma patients have a cervical spinal injury until proven otherwise. Cervical spinal clearance is very important. It is defined as confirming the absence of cervical spine injury. This cervical spinal clearance can be done by either physical examination or radiological or both of them. So for evaluation of cervical spinal patient, you have to go for history, physical exam, bone fractures demonstrated on the X-ray or CT, ligament injury expected from the X-ray by the presence of an abnormal angulation or translation or separation or soft tissue swelling. History is very important and critical. So detail of the accident is very important. The energy of the accident is high level of concern. Look for the motor vehicle accident. If it is more than 35 miles per hour, this means indicating high impact injury. Falling from a height for more than 10 feet, closed head injury, neural deficit, and pelvic and external fracture, if they are present, indicated that there is a high suspicious of cervical injury. What about the mechanism of accident? Elderly person fall and hit the head, which means hyperextension injury. Patient rear end at a high speed and hyperextension injuries. Also, the condition of the patient at the accident places, general condition of this patient, is lost his conscious or not, degree of consciousness, and the presence or absence of neurological deficit. Cervical injury is the most common mechanism of injury is axial load, flexion forces, hyperextension forces, flexion rotation forces, hyperextension with rotation, and lateral frictions. But we can classify the mechanism of injury into traction injury like hangman fractures or seat belt, direct injury like penetrating injury to the spine, particularly from the firearm and the knife, are becoming increasing commonly. The other type is indirect injury. We mentioned before, the most common causes a variety of forces like axial compression, lateral compression, flexion rotation, shearing, flexion distraction, and extension. The last one, which is insufficient fracture, it is a fracture which occur in a diseased vertebra due to the presence of osteoporosis or pathological lesions. The mechanism of injury, which is the most common, is hyperflexion injury, axial compression, and hyperextension injury. For hyperflexion injury, the distraction creating tensile forces in the posterior column, and this can be resulting in a compression of the body on the anterior column, most commonly resulting from motor vehicle accident and falling from a height. Compression injury, it is resulting from axial load and commonly from diving, and this is in the people who is diving in shallow water also have this type of injury, football and motor vehicle accident. The injury pattern depends on the initial head position, either more flexion or straightforward or back extension. This means that the fracture pattern will be changed, creating burst, wedge or compression fractures. Hyperextension injury, which is like from the hitting by a car from the back, it is impacted on the posterior arch and the facet, compressing, causing many types of fracture like laminar fracture, spinous process fracture, and pedicular fracture. With disruption, get disruption of anterior longitudinal ligament. What about the mental state? It's very important to ask about identify the factors that will blunt the physical examination, like the patient has alcoholic or drug in the board, closed head injury, distracting injury, unconscious patient, and intubated patient. So the physical examination is an observation. It's very important. Is the patient moving all extremities or not? Trauma to the head and neck or shoulder, present of bruises, breathing pattern, watching for the intercostal type of breathing. For the physical examination, useful for detecting the major injury. So do the first one is the primary survey, which is the airway, breathing, circulation, visual and manual inspections, and the manual inlet and seat belt signs if there is an abnormal signs of bruise. What about the second survey? Second survey is a cervical examination. Remove the immobilized collar, examine the face and scalp for evidence of direct trauma, inspected for angular rotation deformity, palpate the posterior cervical spine, and rule patient to inspect it and palpate the entire spinal axis. Perform a careful neurological examination. We'll go through it in the next slides. For inspection, inspect for the cervical spine curvature, posture of the head relative to the shoulder, soft tissue symmetry, and the level of the shoulder. And this is a landmark for the cervical plexus, the mastoid process, sternocleidomastoid, external jugular, clavicular head, and the clavicle. Also, the surface anatomy is very important to know. It is inspected from the posterior. Look for the vertebral prominence, the biggest, or at the cervicothoracic junction, the spinous process of cervical 7, C7. Trapezius is the most superficial triangular. Deep to the trapezius is transverse costalis, and the loss of the cervical lordosis, it is non-specific reaction to cervical spinal pain. Also look for the mild deformity stuffing positions. This is the landmark. It is very important to know about how to know this from anterior and from the posterior. Palpated also reveals a supple deformity, detects the paraspinous muscle spasm, point of tenderness, palpates the spinous process in the middle line, tenderness in emergency situation, indicated the spinal instability. It's very important. If the patient is coming to you with a tenderness, you have to suspect that this patient has some sort of spinal instability. Evaluated the alignment is very important. Palpated the posterior facet joint and localize its trigger point in the area superior to the spinal scapula. Anterior palpation, you have many landmarks. Hyoid bone at the level of C3, thyroid cartilage at the level of C4, C5, and the cricoid cartilage is at the level of C6, C7. This is presenting the bony landmark from anterior part. From the anterior palpation, also the sternomastoid muscle can be palpated, and the two head, and also the scalenus muscle in the posterior and posterolateral to the sternomastoid muscle, carotid artery, the primary pulsing point, and the lymph node can be palpated from the anterior when you palpate this patient. Posterior and the lateral palpation, palpate the occipit, transverse process of the spinous process. The spinous process, you can palpate the C7 and T1 are prominent, and you can palpate C5, C6, maybe C3 and C4 in some cases. Trapezius as the upper fiber from the occipital and the cervical spinous process to the distal cervical. This is what called hackstep tender triad for cervical spondylosis, the base of the neck, deltoid insertion, and extensor muscle. Tenderness in the base of the neck, cervical spondylosis, and the prominence of the cervical rib. Examine also for any swelling, like effluent, like an abscess, firm like lymph node, and bony like cervical rib. Also, leg rule, it's very important to inspect it for inspection for abrasion, for contusion. Palpate the occipit to the sacrum, it's very important, and the focal tenderness, and the gibbous in the posterior injury when they have a fractured spine with angular kyphosis. Range of motion is very important. When you're doing a range of motion, it's very important. Having the patient sit in a straight back chair extended to the mid-scapular level, and then examine for all the movement of the spine, for rotation, lateral rotation, and lateral bending. This is an example of how to do the range of motions. Very important is this neurological examination, cranial nerve, motor testing, and sensory for other pathological pinprick, posterior position, vibration, and light touch. This is a neurological examination. We will go through it. It's very important. For C7, we have three things. motor, reflex, and sensation. The motor, it is the deltoid, which is mean abduction of the shoulder. The reflex is biceps tendons, and the sensation at the lateral aspect of the arm. C6 has also the motor, reflex, sensation. Motor, which is the wrist extension, reflex is the brachioradialis tendon, and the sensation as the outer side of the forearm and the thumb. What about C7? The C7 has also the motor, reflex, and sensation. The motor is the wrist flexion, triceps tendons, and sensation is the middle finger or the middle finger of the hand. What about C7? C7 has only motor and sensation, but no reflex. Motor means that finger flexion, and sensation at the inner aspect of the forearm. T1, which is has also motor, sensation without reflex. The motor is the interosseous muscle movement of the fingers, and the sensation in the inner aspect of the arm. And this is the dermatome and the myotome. Also, we can examine by the movement in the myotome. C5 make an abduction of the shoulder. C6 elbow flexion, wrist extension, elbow extension by C7 and wrist extension. C7 finger flexion, finger abduction by T1. This is how to examine the sensation of how to evaluate the cervical dermatome. And when you have this patient, when sensation, you have to examine the motor, and the grade of the motor is very important. It is going for 6 types from 0, no muscle movement, and is complete paralysis. 1/5 means that visible muscle movement, but no movement at the joint. 2/5 movement as the joint, but not against the gravity. 3 to 5 movement against gravity. 4 movement against resistance, but less than normal. 5/5 this normal strength of the muscle. It's very important to make it a grade for the motor grade for the patient who has a cervical injuries. What about the muscle testing? All very important. All strength tests should be done gentle, provided firm control resistant. Lateral rotation, extension, all these has to be in gentle. This is an example of how to examine for the test strengthening of the muscle. This is the motor dermatome examination of the muscle, deltoid C5, C6 biceps, extension of the finger C6, flexion of the wrist is C7, finger extension C7, and C7 in the triceps. And this is an example of C8, the flexion of the fingers, or grip, and also the interosseous for T1. Reflex is very important. We mentioned before, biceps or triceps, brachioradialis. What about the other reflexes? This is a superficial and pathological, like Brabisma. This is neurological. It's very important. Pathological reflex indicated an upper motor neuron lesion, like Babinski sign, Oppenheim sign, and Hoffman sign. And this is the Babinski sign, which is a stretching of the anterior chain of the tibia, make an extension of the toes and the flexion of the extension of the big toe with the flexion of the other 4 toes. And this is the Hoffman sign, which is pressure on the tip of the middle finger, making an OK signs for the first and the thumb and the index. This is some sort of a special test, and this is go for pathology like vertebral artery testing, distraction, compression, Valsova, and swelling of calf, Addison, Sperling signs, grip strength, wedging finger, and pinch. And this can be to complete the spinal examination. This is an example of Babinski test. And the grip strength, this is how you can do a grip test and the measurement. What about the patient with neurological deficit? Is it complete or incomplete? This is mean that to differentiate between incomplete and complete injury of the spinal cord, sacral sparing is indicated of an incomplete injury. The perianal sensation present or not, rectal motor function present or not, great toe flexion activity present to differentiate between complete and incomplete injury. Spinal shock, which is at the time between the injury and the recovery of local spinal shock, spinal reflex. After a severe spinal cord injury, state of complete spinal reflexia can develop over 24 hours to 48 hours. Babinski reflexes significantly end of the spinal shock. This is due to the metabolic rather than structural damage, decrease in adenosine triphosphate that resulting in the spinal cord dysfunction. This is Asia impairing scales, which means that is this patient is a complete paralysis or a complete, there means this patient has sensation but no motor function below the neurological level, incomplete motor function preserved below the level, and the muscle is grade less than 3. Incomplete motor, this is the D, which is the motor function preserved below the level, and the muscle is grade 4 and the normal. This is the American Spinal Injury Association impairment scales. So in the ER, the basic ER management, make a cervical collar on everyone with a neck pain or mechanism that indicates there is a cervical injury, do for him a cervical collar until we do what we call the clinical clearance. The spinal board, puts this patient on the spinal board, removal as soon as in all cases. In major trauma, remove after trauma serious obtained. Then log rule and examine entire spinal and back, and then do full neurological examination on every patient. What about pharmacological management? This is methyl prednisolone sodium succinate, and this is a debate, but still we do this. If the patient coming within the 3 hours, do give him what we call 300 milligram per kilogram as a bolus, and then 5.4 milligram per kilogram per hourly infusion for 24 hours. If the patient coming during from 3 to up to 8 hours, give the same 300 milligram kilogram per kilogram bolus, then 4.5 milligram kilogram hour infusion for 48 hours. And here it's 24 hours, and here for 48 hours. Suppresses, this is the action for methyl prednisolone is to suppress the inflammatory response and vasogenic edema. The initial treatment, first immobilizing this patient by rigid cervical collar, the Philadelphia collar, very important. Postal braces, cervicothoracic orthosis, halo devices. In unstable injuries, this is inadequate and cervical traction required. What type of cervical traction? We have skin, with we'll see it, and skeletal, and we'll see example of that. This is an example of Glisson's cervical traction. This is a skin, some sort of skin traction. It can be done for the patient in unstable condition. And this is a crush field traction, which is skull traction. And this can be done for the patient who has an unstable and for reduction of a cervical injury. This halo traction for immobilization of the cervical spine. And this is the head and shoulder, holding the shoulder with the forepins and prevent the movement and keeping the patient immobilized. And this is a table for recommendation for type of the traction according to the type of the fracture and the vertebral level. For log rule, moving the patient, this is very important to take the patient and to moving the patient, and this is the step starting from rolling the patient, putting the stretchers, putting the patient on the stretcher, and then lifting the patient. And it's very important to avoid avoiding secondary injuries to this patient. This is the general management, and we spoke about, and very important to assess for other injuries. And this is an example of the patient for immobilization with the cervical. And this is how to make a cervical collar. This is what we call Philadelphia collars, and this is immobilization for moving the patient. A specific treatment that we mentioned about methylprednisolone giving in 4 hours for 1 day. And the clinical, this is a very important clinical cervical clearance. This is we mentioned before. This is a clinical cervical clearance, the moving of the cervical collar without radiological study. And when we can do this, you can do it allowed if the patient is awake. If the patient is awake, you can remove and then examine him, alert and not intoxicated, and has no neck pain. There is no complaint, no tenderness or neurological deficit, and has no distraction injuries. This means that you can remove the collar and make an examination to make clinical clearance or cervical clearance. Utilizes updated clinical practical guidelines and also less radiation exposure with reduced CT scan for the cervical spine. By this way, we are reducing the patient to expose to the X-ray and reduces the cost of the treatment. What about the radiological cervical clearance? Indicated for obtaining radiological clearance for the patient who has intoxicated patient or patient with alert mental status or neck pain or tenderness present or distracting injury present. This patient needed to before we do radiological clearance, we have to do an X-ray. Mandatory radiological clearance with either cervical spine radiographer series, and this mostly including the top of cervical thoracic 1 vertebra. This series including the AP, lateral, and open mouth odontoid views. When to obtain the X-ray, CT, and MRI, the modalities available for diagnosis is a plain X-ray, CT, ultrasonography, so the CR, CT, MRI, nuclear medicine, and angiography intervention. So it is very important. It is your responsibility to study this film carefully to either to diagnose and to exclude the other injuries. So approaching to the X-ray, it is very important. Know what the normal anatomy look like. It is very important when you look for the X-ray. Always take a systemic approach. Always a little distance. It can be a good thing that go a little away from the X-ray viewer and look for the X-ray and examine it carefully, and experience counting by looking for more X-rays, you will gain more experience. What about the lateral film in the cervical spine? It's very important. Is the film satisfied? Nothing obscures the jewelry or other oblique penetration. Okay. Very important to know about the syndrome of relative observation. Normal plain film X-ray will go through it. This is the standard views for any cervical injury, odontoid view, AB, lateral, and oblique. Optional views, the swimmer view and flexion extension film for to detect any abnormality like unstable spine. So the three bigs we have to remember. This big three, which is the cervical spine film, lateral view, AB, and odontoid view. This is what we call the big three. And supine chest film in some cases, including AB pelvis film in some trauma teams, routinely includes the lateral lumbosacral spine film to make that the big four. In the film, you look for four things. ABCS, which is the film interpretation, and look for, put this in your mind. ABCS. ABC means look for the alignment of the spine, look for the bony abnormality, look for the cartilage space, and look for the soft tissues. When you put this in your mind, looking for that, you are going to evaluate the X-ray in a proper way. So this is a normal odontoid transoral views, and this is odontoid, and this is the lateral mass. And this is a normal lateral view. It must be including from the 7 cervical with thoracic one. If it's not, this means that this patient can be missing a diagnosis, go for a swimmer view. The lateral view, 80% of injury found in this view, adequate film must see occipital to the T1. This is the X-ray of the cervical spine, and this is the anatomical bony landmark in the cervical lateral mass, the facet joint, the lamina, spinous process, and the pedicle. Also, the very important, the anterior atlantodental interval, which is about 2 to 3 millimeter. This is represents the transverse, the odontoid in relation, and it is about 3 millimeters in adult, and in children can be 5 millimeter in children. More than that means there is an injury to the atlantoaxial bone. And so normal we for the normal lateral alignment, this is the 3 lines. It is very important to see the normal flow contouring of all the 3 lines. And this is an example of the 3 lines, represents the anterior longitudinal ligament, posterior longitudinal ligament, and the spinous process. The curvature to follow, this is the, we will go for this. This is the anterior longitudinal ligament, posterior longitudinal ligament, and the spine. The malalignment of the posterior vertebral body more significant than the anterior. So if there is a malalignment in the posterior vertebral body, means this is significant for the injury. The spinal canal diameter is significantly narrower if they are less than 14 millimeters. Anterior subluxation causes the facet dislocation. 50% vertebral body width is unilateral, less than. More than 50% means that is bilateral facet dislocation. This is the cartilage space, and soft tissue is very important to look for it. And the cervical measurement very important. And this is an example of normal soft tissues, which means that if it is representing the retropharyngeal space and retrotracheal space. For make it easy, is 2662. 26 means that as a cervical 2, it's 6 millimeter. As C6 means that 2 centimeter. So this can be easy for you to remember that's the soft tissue swelling. And this is an example of soft tissue measurement and abnormal, more than 2 centimeters. This is an example, and this C2 and C6. In anteroposterior, the normal alignment is spinous process presenting and the lateral part of the body, and this is an example of the normal alignment of the spinous process. Any disturbance means that there is some sort of rotation or subluxation or instability. Oblique views are very important to know, and this is how to interpret this. This is the green one, which is representing the pedicle on the opposite side, and this is the lamina, which is presenting on the same side, and this is the lines which are representing normal oblique views, and this is the swimmer views to represent the C6, 7, and T1. And this is how you can do the swimmer views. Flexion extension film can be done to exclude the ligament injury in minor malalignment, and the lateral view obtaining during flexion extension has been done by doctor and be not exceeding the painful one. MRI also can be used. Indication for CT, inadequate film plane X-ray, suspicious of plane film finding, fracture displacement, high clinical suspicious of injury despite normal plane film survey. Magnetic, very important. You can obtain MRI to exclude or the acute chordate hemorrhage cord edema and contusion, mixed cord injury, and also evaluated non-osseous structure like acute disc herniation, ligamentous injury, cord compression, cord edema, cord hemorrhage, epidural, and vertebral occlusion. Again, you have to remember, it is your responsibility to study this film carefully, either to diagnose and to exclude. In summary, comparing with level above and below, the transitional of morphology and height should be smooth. Remember the mechanism of injury. Knowing the pattern of injury can help with detection of supple fracture and secondary fracture, CT in any suspicious area. Take-home message: be systemic, review with history and physical examination in mind, and at the last, be aware of the owner, not the dog. And this is how the Egyptian using their resource, and also this one by airbag. Thank you, Dr. Ashab, and thank you for your attention.
Thank you so much, our beloved Professor Bahaa Koranah, for this very, very interesting talk. شكرا جزيلا أستاذنا الفاضل. يعني طبعا يعني احنا كلنا مستمتعين بالتوك يا دكتور بهاء بيه.
الله يخليك، ربنا يكرمك.
We are ready to receive questions to Professor بهاء. هو في question حضرتك من دكتور محمد عبد العال، طبعا بيسلم على حضرتك جدا يا فندم. هو حضرتك بيسأل what about the your experience, sir, with steroid injections in acute cervical injuries, acute traumatic injuries of the spine?
والله احنا بندي في الاكيوت انجري هي كونتروفيرس. في ايام الناس طلعت دلوقتي بتقول has no rules، لكن احنا ما زلنا ماشيين على المدرسه القديمه ان احنا بندي الانجكشن. لكن طبعا دي حاجات يعني الاكسبكتيشن ما تقدرش تعرفه، لكن انت لازم تعمل ري الاينمنت وبتدي نفس كميديكال تريتمنت ونشوف الاوت كام بتاعها. لكن الاكسبيرينس بتاعتنا ان هي الاوت كام بتاع العيان هو اذا كان هيتحسن، مش هيتحسن برضه مش هيتحسن. ما تقدرش تقولها يعني 100% ان هي beneficial او non beneficial.
تمام يا فندم. We have another question, sir. Does evolution of CT and MRI make the role of conventional X-ray in cervical injuries less significant?
لا احنا قلنا وحاطين سلايد قلنا 85% في اللاترال اكس راي جود اكس راي هتدي لك ممكن توصل ل 85% من الدياجنوستس اوف ذا انجري اوف ذا cervical spine. فانت تاخد جود كواليتي اكس راي مع واحده with adequate levels، يعني واحده لازم تبان البيز اوف ذا سكال وتبان تي 1، ده هتدي لك جود اكس راي. لكن احنا بنلجا للحاجات الثانيه زي السي تي والحاجات دي زي ما قلنا ليها سم انديكيشن. يعني افرض بيشنت انا عملت له الكليرنس ومع ذلك برضه جالي بقى بنيك بين، ممكن يكون عنده سبب ثاني ما زال انا مش هيدن، اقدر اعمل السي تي، او عملت له ومشي كويس بعد كده ابتدى يجي لي مثلا براديكولوبيسيس، فمعناها ده ممكن يكون عنده سوفت ايش انجن، فدي مش هتبان الا عن طريق الام ار اي. لكن ما اقدرش، لازم اخد ستيب باي ستيب. وبعدين لوكينج فور ذا كوست، ان انت لما البلين اكس راي احسن وارخص وفي نفس الوقت تدي لك جود ايديا، لكن انت بعد كده تقدر تبقى شيفت للاذر، والا كل الار تي اي دول اللي هيجوا هتدخلهم تعملهم سي تي وام ار اي يعني very costly.
Yes, sir. Another question, sir. What's the main difference between cervical injuries in adults and children?
الchildren بيبقى عندهم الليجامنت لاكسي كويسه بتاع، لكن في عندهم حاجه اسمها سكورا، دي حاجه بيبقى انجري وزاوت بنفستيشن، اللي هو بيبقى ديستراكشن وانجرز ما تبانش. الاطفال بيبقوا من الحاجات اللي هم عندهم الليجامنت لاكسي يعني عندهم اللايبيلتي والالاستيسيتي اعلى شويه، فالاصابه بتاعتهم بتبقى اخف، عشان كده بيقعوا ويتنططوا ويتخبطوا. لكن الكبار السيرفايكال بيبقى ستيف، وكل ما تقدمت في السن بتبقى ستيف، فالانجريز بتبقى مور مانيفستيشن، ليها مور او ليها مانيفستيشن، وفي نفس الوقت العيان بيبقى بريزنتنج باي نيورولوجيكال ديفيسيت اعلى شويه.
Yes. دكتور بهاء بيه finally thank you so much sir for this very interesting talk. نشكر سعادتك شكر جزيل على المحاضرة الرائعة دي يا أستاذنا، وإن شاء الله طبعا إحنا ما نقدرش نكمل إلا بوجود حضرتك، فحضرتك معانا في أي نشاط أي اكتيفيتي ما نقدرش نستغنى عن حضرتك دكتور بهاء بيه.
ربنا يكرمك.
ربنا يكرم عليك يا أستاذ، شاكرين جدا يا فندم. إحنا معانا محاضرتين تانيين دلوقتي مع بروفيسور